Good morning, I'm Teoh, specialist in obstetrics and fertility care in Perth, Australia. The book that I've written a chapter on has just arrived. This book costs $250 USD, probably $350 Australian. Very expensive. As a writer, I do get 20% off, but I still have to pay for it, plus transport. I thought it's going to be bigger. It's one of the most expensive book I've ever bought. It's smaller than I thought. I'm just trying to show it to you. 6 chapters, quality chapters though. I've written one of them. So this is I'm not sure whether you can see it. You can see my name there. Basically, I've written on the topic of artificial intelligence computer in helping doctors, or is it replacing doctors? Helping doctors and clinicians in providing the best care for patients. Computers are very good actually in vision. So even in IVF, we use them to look at our embryos, helping embryologists in making decision in choosing which embryos and in helping to nurture them, the embryos. Right. That's about the book. Today, the topic I'm going to talk about is my mentality is always preventing cesarean section for the suitable patients, for appropriate patients. Please stick to me towards the end. I'm kind of let you know from my public and perhaps more private obstetrics experience what patients looking for with our advice. The number one rule is always safe mom, safe baby. However, you still want to decide, if you're aiming for natural birth, vaginal birth, while it's still safe, how far we should carry on. So let's start with the different patients. For example, I have patients coming in, very clear says, I've spoken to different people. I've got relatives or friends who has gone through long labor and then outcome is not quite what they were expecting. Maybe end up with difficult delivery or perhaps a emergency C-section. So they walk in, they'll say, everything goes well. They'll tell me, I know the pros and cons. We have discussed everything in details, and they say, C-sections for them, they just want the predictability, so they know, okay, it's going to be calm, everything's going to be done, section done. And I've done a few of those with patients' request, and I think it's reasonable. It's predictable, safe, and quick as well, not going through perhaps long labor. That's what they're trying to avoid. And I've got second group of patients. I'm trying to very generally kind of, talk about 3 types of patients. So we talk about the first type. Second type, but certainly it's not quite fixed in those 3 types. There are always a breach in between, where I'm happy to continue to discuss all through the pregnancy. If they change their mind or there's a bit of different plan being made. I've got patients coming in says, I'm aiming for natural birth, vaginal birth, but if it's going to be not as smooth sailing as I'm expecting. So, I want to resolve to perhaps cesarean section before things got too rushed, before it becomes a bit more difficult. So basically, it's not written in stone. In labor, I continuously looking after my patients, discuss with them to say, what's the best way to carry on in planning to deliver the baby when they're in labor. So I've got patients who would say, for example, a patient's gone through labor, it's quite well, and then up to a few hours later, suppose 4, 5, 6 hours, just kind of arbitrary, it's not fixed, and then discuss labor hasn't gone through quickly, they're quite painful, so sometimes for the choice to say, okay, shall we put in epidural? If they can't cope with the pain, they say it's too much, and I can put up syntocinon to see, can we boost the contractions and let labor carry on? And many patients say, yep, let's do that, and many times to achieve a natural birth. However, I've got patients who say, look, no, this is too much for me, give them some time to think about it, still think, look, yeah, if I'm going to have epidural, if I need to carry on with stronger contractions, let's call it quit to do a cesarean section. Or sometimes might see signs of baby to say, look, yeah, I'm coping, but baby may not be as active as we are expecting. So it's a combination. Some patients will tell me, look, after calm thinking about it, calmly, and then we think, okay, let's organize a cesarean section. I think that is a reasonable decision for some patients, and then cesarean section can be organized, and we carried it out calmly. Well, I've got patients that we're planning for cesarean section and go to theater. I always do a last examination in case they're fully. Then I ask them to start pushing. It has happened. So before cesarean section, I always do an examination and see what's happening. And if they're fully, they can push. Sometimes we can achieve a vaginal birth even in theater before we start the cesarean section, which is amazing. Or sometimes give them a hand by doing instrumental delivery. Now we got patients, and which is what I encourage patients to. If you're aiming for vaginal birth, aiming for natural birth, then as long as it's still safe, we don't rush into do a cesarean section. Doctors and patients should have the mentality to, while it's safe for mom and baby, once again, to prevent and avoid a cesarean section rather than wanting to rush to a cesarean section. That's my mentality, which is what I pledge to my patients aiming to achieve a vaginal birth or natural birth. Take an example of a patient over the weekend. We decided to induce at 39 weeks, big baby, off the scale, very high up in the charts. We have been monitoring closely. We thought, look, and there's a few things we thought, look, we don't want to drag on too long as well for safety of baby from ultrasound scan. So we thought, look, 39 weeks is a good time. Baby is fully matured. Let's do an induction. So we induce. And at the end, we need to put out the oxytocin. After a while, we realized baby is not really liking contractions. We're just starting contractions, and baby's heartbeat's slowing down on occasions. Looking at the pattern, it's not the best pattern. However, it's not one of those pattern I have to rush in to do a cesarean section. I thought, look, maybe we can wait and see. So I turn down the oxytocin and stop it. Wait for a little while. Theater team is ready. They're around. So we thought, look, let's continue monitoring. So I basically sit in the room for a few hours. Communicating with patients, reassuring patients. Baby is so far still healthy. After stopping the oxytocin, the contractions slow down a little bit. And baby is becoming really active, jumping around, really happy baby. And I thought, look, maybe, but there's not much contractions. And patient's still about 3 centimeters, not going as fast as we would hope for. And then I thought, you know what, let's start oxytocin a little bit again. And then slowly, there's no rush. We keep going over a few hours. And then contractions getting stronger and stronger and stronger. Few hours later, you know what? When examined, we are fully dilated. Although it's a big baby, but we managed to avoid the cesarean section. So this case shows that obstetricians and working with patients should have patience. And my motto is basically, I don't think it's fair to do a cesarean section for no reason, and let patients know, look, we need to rush into a cesarean section. If we can, if it's safe, we have to be patient, and I have patients waited for the whole night, just because patients and we were committed to achieve a natural birth, vaginal birth, and in many cases managed to do that. For patients aiming to achieve a natural birth, we should aim to avoid cesarean section and aim for the lower cesarean section rate in both public and private care. Right, that's about it for this time. See you again next time. Bye-bye.